Thank you. This time, yes, it was 10 minutes, which I was told. Again, this case selection for surgical and interventional treatment in peripheral vascular disease. Now, the incidence, as I told you in the last talk, again, rises depending upon what are the parameters you're using, whether you're using intermittent claudication, or you're using ABIs, or you're using any other things like color Doppler, and it rises quite a bit. For instance, at 75 years, it was using intermittent claudication, it's 7.7%, but it rises to 22% if you use more diagnostic indicators. Now, whenever we talk of this topic, we must know the natural history and the prognosis. Now, whenever you see in natural history a patient who's got peripheral vascular disease, we find that claudication is the commonest and the first thing that appears and the first symptom that he complains of. 2/3 of the patient will remain constant. They do not need any intervention. 1/3 of the patients will deteriorate, and they do need intervention because they'll go on to rest pain, ulcers, and gangrene, and ultimately limb loss. Whatever you do, 1 to 5% will ultimately need amputation at some length in time. Now, 50% of our patients with peripheral vascular disease do have some sort of cardiac problems because, as you know, peripheral vascular disease, atherosclerosis, is a generalized disease. If you take a clinical diagnosis, we found that the mortality rose quite a bit, but if you took non-invasive, it even rose more than taking intermittent claudication. Now, the case selection is very simple. You all know angiogram is today the gold standard, and after angiography, you decide most of the things. Of course, severity of symptoms, whether it is claudication, rest pain, ulcers, or gangrene, that is important. What is important also is the duration of the risk of each therapy. Now, you do something, you've got statistics all over the world which show you that a patient who's had a stent put in interventionally, and we find that in these cases, there's a certain duration, but if you do surgery, it may be more or less. So that is another criteria which is going to rule your decision on whether what is the procedure you should do. Then it is the site and the length of the stenosis or the occlusion, which again will decide. If it is exceptionally long, like whole of SFA is occluded, it is very unlikely that interventional work, a large stent or anything could be done. It is mostly got to be bypass, which is done. Again, one of the important things in any study is to look for the quality of the distal runoff. You know, diabetics, small vessel disease, the runoff normally is not very good. But if the runoff is not very good, there's very little you can do about it. And they always, mostly, their prognosis is bad. Again, it varies on the skill of the specialist. In certain centers, they are very highly skilled, and they'll do interventional work which is very good and give the same results like surgery, whereas other centers, they may not be highly skilled. The costs involved, in our country especially, if you have interventional work, you may find that in aortic abdominal aneurysms, the cost of intervention is very, very high because the grafts are so expensive. You may like to do a bypass because the patient can't afford it. Again, the period of hospitalization is important, and the morbidity, what it is expected. So all these criteria decide what you want to do. The indications for angioplasty, as you all know, are of course persistently limiting claudication, not only claudication, limiting claudication, rest pain, tissue loss, and of course people who are poor surgical candidates from other conditions like cardiac problems or other problems which can cause them to have surgical intervention become difficult. At times you want to preserve the long saphenous vein for cardiac work, and in these cases you may think of doing a stenting, and so to prevent this thing, or you may use a synthetic graft. Sometimes the long saphenous vein is not usable, in which case you again may think of an angioplasty. Now, what are the indications for surgery? Normally, these are changing rapidly. Why? Because now the interventional work is becoming very good. But long segment stenosis normally, if they are very long, of course, needs a bypass surgery. Although, as I said, things are changing very rapidly. Multifocal lesions, you've got in the long saphenous, 4 blocks, you normally say, instead of doing angioplasty for all of them, let me consider surgery in these cases. Long segment occlusions, like I said, whole of the long saphenous vein, whole of the SFA is occluded. Then in that case, you may consider surgical intervention. Again, calcified lesions where dilatation may be a problem and you can't do it in that. Or sometimes occluded bypass, vein bypasses, or synthetic grafts which have been included, you may think of surgery, although intervention again is a possibility there. Now here are some of the results to compare the various lesions. In eye-to-iliac occlusive disease, you may find that in normally angioplasty, the success rate initially is very high. But over time, it progressively falls, and at 5 years falls to 50%, whereas if there's poor distal runoff, it may come even further down. In surgery, you find the results really good. Although the mortality may be slightly higher, you may find at 5 years, it is 85 compared to 57 there. And as it progresses at 20 years, it may come down to 55%, which is reasonably good compared to angioplasty. Axillofemoral or femorofemoral crossover grafts, again, at 5 years, we normally use in these cases the grafts, and it is 50%. And iliofemoral bypass gives, again, excellent results, as you can see. Femoropopliteal bypass, femoropopliteal occlusive disease, again, if you use angioplasty, initial success is very good. But at 2 years, the patency falls dramatically to 52%, and at 5 years, 38%. Now, again, which is changing over time. In surgery, the results are much healthier. As you can see, there's 75% and 65% using synthetic graft. Below knee results and angioplasties till late have been poor. Immediate success is good, but you can see at 2 years they dramatically fall to 42%, whereas in surgery it is 80% at 3 years and 50% at 5 years, which is much superior. Now, in diabetics, we normally, as I said, it's a small vessel occlusive disease, and in this particular case, you will find that surgery is normally not indicated. People have tried angioplasties. Here's a survey showing 29 patients using antiplatelet and anticoagulation. And here, using stents, the results were okay. 75% ulcers healed, and at 12%, they avoided BKA. Again, tissue oxygen, which was one of the parameters, improved. Now, angioplasty for bypass grafts may be used. And let's skip this. Why are there poor results of this? Because of the intimal hyperplasia, progressive atherosclerotic disease, calcified lesions, very long occlusive lesions, poor distal runoff, and interestingly, repeated PTA has the same results as the primary PTA. So that is one thing which is good. Now, comparing the two, that means PTA and surgery, these can't really be compared. Why? Because the protocols are different in different places. There are no two patients which are identical. The criteria for patient selection is important. Some people are using claudication, some people are using different parameters. The clinical success, what are you going to rate it with? Is it angiography? Is it the clinical improvement, that means claudication distance, or is it non-invasive testing? And patency, what are you going to do? Is it residual stenosis, or is it the pressure gradients which are going to decide? And finally, the follow-up. So comparison is really very difficult. Why? Because most of the trials are multicentric and different places are different criteria. The techniques are improving so rapidly that even as when I wrote this, things have already changed. So you cannot be sure. The stents are much better and the results are much better. And of course, it's difficult to standardize the things. The worrying trend, the last slide, is that despite all our intervention, the amputation rate has not fallen in the world. that means there's something wrong. And what is it? That though we are doing a lot of surgeries, a lot of things at the same time, and angioplasties has increased multiple folds, but still the amputation rate is not falling. Why? Because it may be unnecessary what we are doing many times. Thank you very much.
Just one question, please, ma'am, because we've run out of time for this session and we have to keep to the time duration.
About the hybrid procedures, that surgeon and interventionist working together.
Yeah, that's a very, very good thing, because sometimes you do need, and especially many times in the aortic things, you may find that the major vessels are occluded. So you do a surgery before and then put a thing. Yes, it gives you excellent
Because I
results.
think it really decreases the morbidity of the patient, that maybe iliacs you can handle by intervention and
I regularly do that.
put
And
a
for
graft.
instance, if there is a stenosis of this, Dr. Khanna has been doing that for us, and many times we have got stenosis of the iliac vessel, along with the SFA is totally occluded.
Yeah.
So naturally, once you don't have to open the abdomen in that case, you just put a stent there, improve the inflow, and then you put a graft for that, and which you can even do under local anesthesia. So it's not.
Yeah, so
something
the
which is-
teamwork can really help a patient with peripheral.
Yes, it does help a lot.
Dr. Chopra is very good description and deliberation you have given. But I would like to ask you one important thing, that why there is more reocclusions and the not that good results as in the central arteries in comparison to peripheral arteries?
Well,
What do you
because-
think is the reason? Because they are the bigger arteries, and but the results of the interventions, stent, bypass, or anything else?
No, the thing is that the arteries peripherally are much narrower. And as you go, and atherosclerosis, as you know, is a progressive disease. If the patient is a diabetic, it's even worse. So with the result that as it goes, the size of the vessels are so small that they are going to cause, as it progresses, you've done a bypass, which you initial investigation, like many times we see, when we do a bypass and there's a problem again, either when they follow up, and color Doppler shows that the flow is reduced, we check up. We many find there's intimal hyperplasia. Why? Because the vessels are very narrow there. And that is why they're taking place. So why I think is, one, it is a low flow system compared to the high flow system above the inguinal ligaments. Second thing I find that it is because of the narrowing of the vessels which is there, and this is a progressive disease.
Narrowness is both ways, in the central arteries as well as in the peripheral
Yes,
arteries.
but the diameter is much larger compared to these there,
But
especially peripherally.
when you go to arterioles, it will may be same, at the peripheries also, in the central arteries as well as in the peripheral arteries.
Well, it's one, as it progresses, I feel that is the main criteria in this particular thing.
I was finding out in the literature, but I didn't find any reason for it. Why the progression and the failure of the procedures being done, interventions being done in the peripheral arteries are not that satisfying as in the central arteries.
Well, maybe somebody could tell you this is.
No, maybe anybody from the experts. I'm not expert in peripheral arteries at all.
I don't know if anybody's got that. But what I think was the main thing is the size, and of course is that and the low flow systems and this which are responsible for it.
And the data which you have given to us, are they from India or they are from the States and Europe?
No, India is not very much data I've got from here.
So therefore we are worried in India about the loss of leg or the amputations,
Yes.
mainly.
Yeah.
And of course, a very severe morbidity.
I think that this is a peripheral disease is, and the statistics would be the same as those countries. Maybe they've got, because of the more high-class work, maybe the longevity would be better. But today, things are really improving in our country also. And I feel that, yes, things would improve. And the data would be identical, because if you see many of the diseases, when I came back from UK, they said that there's no peripheral work in this country at all. And I was really shocked. I said, if people smoke in this country, how is there no peripheral work? And today, Again, as you know, there were no peripheral veins, there were no varicose veins, there were people didn't know, and that. But today, this tremendous work in all these fields.
Yeah.
It is that it is not tapped. It is because people do not know. In fact, it is many doctors sitting in the periphery have no idea peripheral work.
They keep on suffering, they keep on suffering, they
Yes.
don't report, they are not diagnosed.
Yeah,
They keep on
absolutely right.
suffering, and they don't have the money to come back.
Absolutely
They don't
right.
have experts.
Absolutely right.
That is what is true for the India.
Absolutely.
But I
what-
think with the cardiologists pitching in, there is increase in the peripheral work, and plus with the help of vascular surgeon, the awareness.
Yes, it
The
is.
load is increasing day by day.
Because there are not many vascular people. I remember when I came, there were only 2 people in this city, this huge city. And today there may be a dozen or even less than that, 6, 7 or even less, I mean that way, of people. But I'm sure as things improve, and it will become
And thanks to
better.
Dr. Khanna, I think he's creating a lot of awareness amongst the crowd.
Thank you very much indeed, Dr. Jason Chopra.